Good afternoon from Miami Beach. This is Dr. John Bennett broadcasting another in the series of AFAN neurosurgery, skull base and neuroanatomy series. And this is, I'm not sure if it's the 11th or 12th. I'm getting confused lately. However, we have Dylan Giojak, a medical student from Cameroon, giving a lecture on Medulla Oblongata. And first, let's introduce Ivan Jose. Hello, Ivan. Could you please introduce yourself? Hello, Ivan. You're muted there, Ivan. Let me unmute you.
Ivan, unmute.
Okay, you're muted there, Ivan. Oh, okay. Okay, Dylan. He'll be back, and welcome, and thanks for being here. It's all yours.
Okay, thanks, John. I'm Dylan Jofak, a seventh-year medical student from Cameroon and member of the Association of Future African Neurosurgeons. So this is part of our neuroanatomy and skull-based series. Today we are going to talk about the medulla oblongata. So I'll be sharing yeah. We're going to.
Okay, you're sharing.
Okay.
Okay. You're going to get the screen bigger there? Okay, yeah. You know how to do that, right? Okay. There we go. Perfect.
There we go. Okay. So what we can say is, in order to fulfill our objectives of the day concerning the surgical anatomy of the medulla oblongata, we are going to follow a plan. I don't know what's happening.
You okay there, Dylan?
I have some trouble with the PowerPoint presentation.
Okay, no problem. No problem. We can edit this out. No problem. There you go. You got the plan. Okay.
Okay. So we are going to follow a plan, including a brief introduction on the medulla oblongata. We're going to talk about the embryology. We're going to talk about the surgical anatomy. We're going to talk about the functions of the medulla oblongata to see a little bit on which organ we are engaging during the surgical procedures. We're going to talk about the clinical relevance of the medulla, of studying the surgical anatomy of the medulla oblongata, and then we're going to see some surgical approaches. So, as an introduction, the medulla oblongata is that most inferior part of the brain stem that originates embryologically from the neural tube. Precisely, it is formed from the myelencephalon, this secondary vesicle formed by the 5th week of development, originating from the rhombencephalon. So during this formation, as part of the neural tube, we have the roof plate. So we have the roof plate on one side, and then the roof plate right here. And then we have the ala lamina and the basal lamina, which are separated by the sulcus limitans. So during the development of this medulla oblongata embryologically, this sulcus limitans separates the dorsal ala lamina, which is going to form part of the cells of the cranial nuclei, and then the ventral basal lamina, which forms the motor nuclei of the cranial nerves of the medulla. So here we see exactly which cranial nuclei originate from the ala lamina and the basal lamina. We see the ala lamina gives the vestibular nuclei, the nucleus of the spinal tract of the trigeminal nerve, the dorsal nucleus of the vagus nerve, and the basal lamina of the embryonic cerebral vesicle will give the dorsal nucleus of the vagus nerve, the inferior salivatory nucleus, nucleus ambiguus, and the hypoglossal nuclei, which both will give the cranial nerves that we know in the adult. So in a fully grown adult, the medulla oblongata is that most inferior part of the brain stem, and most inferior part of the brain stem, which has a cone shape with a base oriented superiorly, continues with the pons just above here. It measures 27 to 30 millimeters of length, 12 to 15 millimeters anterior posterior diameter, 12 to 25 millimeters as in transverse diameter on the superior extremity, and 10 to 12 millimeters at its inferior extremity. It's limited above by the pons here, and then inferiorly by a horizontal plane that causes just below the decussation of the pyramids above the first cervical spinal nerve. So here we can see the atlas, the first vertebra. We can't clearly see the first cervical spinal nerve, but the horizontal limit is that plane that causes just below the decussation of the pyramids and the first cervical spinal nerve. You have to note here that the bone limit of the transition between the medulla and the spinal cord is a plane linking the middle part of the anterior arc of the atlas with the superior border of the posterior arc. So here we can see again the limits of the medulla oblongata. We have superior limit here with the pons, and the inferior limit at the level of the first cervical spine, the first cervical spinal nerve, horizontal line going through the first cervical spinal nerve, which you can see here well, but we have our medulla oblongata right here. Talking about the external morphology of the medulla oblongata, we see that we have an anterior surface to the medulla oblongata, we have a lateral surface, and then we have a posterior surface. So on the anterior surface, precisely at the level of the midline, we have what's known as the anterior median sulcus, which ends superiorly at the pontomedullary junction between this medulla and the pons just above, as the inferior foramen cecum is interrupted inferiorly by the decussation here, the decussation of the pyramid, and extends further 6 to 8 millimeters. It is located at the level of the pyramid. It is located in the middle, and on both sides of the sulcus we have the pyramid. So we have the anterior median sulcus of the medulla oblongata. Here again, we can see here we have an anterolateral view from the right, depicting the two pyramids and then the median, anterior median sulcus, which is here. The pons just above, and then the sulcus is the decussation here, and the extension of the anterior median sulcus. On the posterior surface, we divide the anatomy of the medulla oblongata into two parts. We have the superior part and the inferior part. The superior part on the midline is represented by the inferior half of the floor of the fourth ventricle, the inferior half, and laterally the inferior cerebellar peduncles on both sides. Going more into details concerning the lower half of the fourth ventricle, the fourth ventricular floor, because we know that during surgical procedures, there are certain procedures at the level of the medulla oblongata that entail an intraventricular approach, precisely those concerning this lower half of the fourth ventricle. So this lower half is also called the inferior or medullary triangle of the fourth ventricle, or the calamus scriptorius, and it presents important structures such as the obex, which is made up of the gray commissure fibers. We have acoustic striae, stria medullaris. We have the inferior trigon, which has three areas with a hypoglossal trigon here, a vestibular area on both sides, and then an inferior fovea. So we have also the area postrema, which is that region of the medulla oblongata, that chemoreceptive region that is responsible for the response that we have to blood-borne noxious stimuli which cause vomiting. Here we have a representation of the floor of the fourth ventricle, the inferior part right down here, with the stria medullaris, as we were talking about it. We have the hypoglossal trigon, the vagal trigon, the obex, and then the area postrema just above here, the obex, this chemoreceptive region. Here again, we have a representation of the posterior surface of the medulla oblongata, precisely the fourth ventricle. You can see the hypoglossal triangle, the vagal triangle, the stria medullaris on both sides. Still in the external morphology, at the posterior surface, we have the inferior part divided into two halves by the posterior median sulcus. Each half comprises medially the gracile tubercle with its gracile fasciculus, and laterally the cuneate tubercle with its cuneate fasciculus. Just have to precise that these gracile and cuneate tubercles are actually the nuclei that permit relay of the sensory neurons in the sensory tracts for touch and vibratory senses. So I have the gracile and the cuneate tubercles with the fasciculi on each side, separated by the posterior median sulcus or the dorsal medial sulcus, and these two tubercles are each separated by the posterior intermediate sulcus. Concerning the lateral surface, is limited anteriorly by the anterolateral sulcus, well represented here, but posteriorly by the posterolateral sulcus, and is formed by the lateral cord of the medulla. On this lateral surface, we can see at the anterior superior region the medullary olive, which is internally represented by the inferior olive. It is separated from the pons above by the supraolivary fossa, which is the origin, the apparent origin of the cranial nerves 7 and 7b, the intermediate nucleus of the cranial of the seventh nerve. And then we have a small depression behind the supraolivary fossa called the lateral medullary fossa, from which the cranial nerve number 3, the common oculomotor nerve, arises. And this medullary olive is separated from the pyramids just here by the anterolateral sulcus or the preolivary sulcus, from which arises the hypoglossal nerves. Present at its posterior edge, we have the retroolivary sulcus just behind the olivary, the medullary olive, the retroolivary sulcus, which will give rise to cranial nerves number 9, the glossopharyngeal, the vagus, and the accessory nerves, some rootlets of the accessory nerves. Here we have a clearer image that represents this olive with the retroolivary sulcus, with the cranial nerves originating from them, and then the preolivary sulcus with a cranial nerve number 12, originating the hypoglossal nerves originating from the preolivary sulcus. And then we have the supraolivary fossa, as we said, from which will arise seemingly the cranial nerves number 7 and the cranial number 7 bis. Here again, we have an image still showing the anterolateral surface with our olive, the origin of cranial nerves number 9, 10, and 11, and then the cerebello-medullary fissure just behind here. So, talking about the internal morphology, because externally we have those landmarks, but internally the medulla has a certain number of particularities to consider. So internally, similar to the structure of the spinal cord, the medulla oblongata has gray matter and white matter, like the parts of the brain stem. But it has a certain number of structures that are similar to those of the spinal cord, and other structures that are different from those of the spinal cord. It differs from the spinal cord first in the gray matter, in that it has certain number of nuclei that are specific to the medulla oblongata that are not present in the spinal cord. The white matter of the medulla oblongata exerts what will be visualized as a decussation of the pyramids, these fibers of the corticospinal tract, the motor decussations, and then we have also sensory decussations, precisely for the fibers originating from the gracile and Kugnet tubercles, the arcuate fibers. And then posteriorly, again, another particularity that separates the medulla from the spinal cord is that this opening, the posterior opening of the fourth ventricle at the level of the medulla oblongata. So talking about the gray matter, this gray matter that separates the medulla oblongata from the spinal cord, the gray matter can be divided into gray matter homologous to the spinal cord, that's cranial nerves, knowing that at the level of the spinal cord there are also nerves, but those are peripheral spinal nerves. At the level of the medulla there are some cranial nerves, and then gray matter specific to the medulla oblongata. Precisely here we're talking about the inferior olivary nucleus here. We're talking about the gracile and Kugnet nuclei. We're talking about the medial and dorsal olivary nuclei and the gray matter of the olivary formation. So concerning the gray matter, which is homologous to the spinal cord, we talked about the nuclei of the cranial nerves. We have the ambiguous nuclei or the anterolateral nucleus of Stilling, which gives efferent stimuli, efferences to the cranial nerve number 9, glossopharyngeal, the vagal, and the accessory nerve, which in turn will control the muscles of the pharynx and the larynx. At the level of the hypoglossal nucleus, we have efferences that go to the hypoglossal nerve, the 12th cranial nerve pair, and which will be responsible for control of the tongue muscles. We have the dorsal motor nucleus of the vagus nerve, which contains nuclei of the preganglionic neurons that leave the vagus nerve. Moreover, we have the vestibular nuclei, this vestibular part of the which receives efferences from the vestibular part of the 8th cranial nerve, the vestibulocochlear nerve. We have the solitary tract nucleus, which receives efferences from visceral fibers themselves, receiving information from the cranial nerves number 7, the glossopharyngeal, and the vagus nerve. We have the spinal trigeminal nucleus. This nucleus that receives sensory efferences from the face and brings those efferences through the trigeminal nerve. And then we have the inferior salivary nucleus, which at the level of the origin of preganglionic nerves that follow through the glossopharyngeal nerve to innervate the parotid gland. So these nerves receive the stimulation or the influx to the nerve impulses from the inferior salivary nucleus. Here we have an image that depicts this gray matter of the medulla oblongata that's specific to this medulla oblongata. So we have the dorsal nucleus of the vagus nerve. We have the abducens nuclei as part of the nucleus that are present. We have the motor nucleus of trigeminal nerve. Amongst other nuclei, all of these nuclei being part of the medulla oblongata's gray matter. Here we have a lateral view with our olive here. On this side, we have the fibers for the hypoglossal nerve, which is corresponding nucleus posteriorly here. And then here on the retroolivary sulcus, which will be represented laterally, we'll see the nerve fibers, which concern the glossopharyngeal nerve, the vagus nerve, and then the accessory nerve. Further talking about the gray matter specific to the medulla, we have the inferior olivary nucleus or olivary nuclei when talking about the both sides. So as we said, it is on the surface, it is represented by the medullary olive here. and it receives afferences from the cerebral cortex, the spinal cord, and the red nucleus. It connects to the cerebellum via the olivocerebellar fibers. Here again, we see an image that depicts this olive. Internally will be represented by the inferior olivary nucleus. So on the surface, it is the medullary olive connected to the cortex, cerebellum, and it sends impulses to cerebellum through the olivocerebellar fibers. Next, we talk about the gracile and the Kugnet nuclei. These nuclei that permit relay of information from the sensory tracts that manage the vibratory sensation, as well as the tactile, superficial tactile sensation. So they are represented on the surface by the gracile and Kugnet tubercles at the posterior surface of the medulla oblongata, and they give rise to internal arcuate fibers. So here we can see internal arcuate fibers crossing here, and they give rise to internal arcuate fibers which cross the midline as they ascend to the medial lemniscus. Normally, medial lemniscus will be medially here. The gracile nucleus, as well as the Kugnet nucleus, which will give rise to these arcuate fibers, which ascend as the medial lemniscus as part of the spinal medullothalamic tract. So here we have a representation still of this posterior surface of the medulla oblongata, with here the gracile tubercle, Kugnet tubercles laterally, the gracile fasciculus on both sides separated by the posterior median sulcus, and then the Kugnet fasciculus laterally by the separated posterior intermediate sulcus. Here again, you can see the inferior surface of the foot ventricle, and then our gracile tubercle and our Kugnet tubercle more laterally. So we have the medial and the dorsal accessory olivary nuclei, which have basically the same structure and connect with the inferior olivary nuclei together to form the inferior olivary complex. Talking about the white matter of the medulla oblongata, it structurally comports an anterolateral cord which harbors the two pyramidal fasciculi, the Gower's fasciculus. Don't know how. The Gower's fasciculus. Posteriorly, we have the ascending anterolateral fasciculus, and then the posterior cord on both sides, which harbors the gracile and the Kugnet nuclei. Fasciculus solitarius, the gracile and Kugnet nuclei not well represented here. And then the fibers anatomically can be organized into longitudinal fibers and transverse fibers. Talking about the transverse fibers, they are divided into internal fibers. These internal fibers are represented by the arcuate fibers, which originate from the gracile and Kugnet nuclei, which cross the midline to ascend in the medial lemniscus, and then the external fibers, which cross on the surface of the medulla and enter the cerebellum through the inferior cerebellar peduncle. So here we have an image that shows precisely how those fibers originating from the spinal cord ascend and then cross the midline here, forming the arcuate fibers to ascend in the medial lemniscus and then get to the parietal cortex. Still talking about the white matter, concerning the longitudinal fibers, they are divided into ascending fibers, descending fibers, and associative fibers. So the ascending fibers mostly include sensory fibers, and on the other hand, the inferior cerebellar peduncle. In the sensory fibers, we have fibers of the spinal medullothalamic tract concerning the gracile and the Kugnet fasciculi, which ascend in the medial lemniscus. We have spinal thalamic tracts responsible for pain and temperature sensation. And then we have the spinocerebellar tract responsible for unconscious proprioceptive perception, which go through the Gower's fasciculus and the Fleschig's fasciculus. So here we have an image of this ascending tracts from the spinal cord, which ascend. We have the Kugnet nucleus and then the Gracile nucleus. From there, we have the relay, which cross the midline level of the medulla and ascend the medial lemniscus to get to the thalamus and then the parietal cortex. Here we have the spinocerebellar tract, which is responsible for the control of unconscious proprioception from spinal stimuli due to receptors present at the level of the joints and then the tendons. Concerning the descending fibers, they mostly include the motor fibers, the corticospinal tract, corticonuclear tract, and the extrapyramidal tracts. Moreover, we have the spinal trigeminal tract and then the solitary tract. So, concerning the corticospinal and corticonuclear tracts, these are the fibers originating from the cortex, which get down through the internal capsule and then get to the brain stem. At the level of the brain stem, they go anteriorly. Have the corticonuclear fibers that will cross the midline and go to the motor nuclei of the cranial nerves, and then part of it reach the medulla oblongata. This part is the corticospinal tract, reach the medulla oblongata, and then majority of this tract will cross the midline to the contralateral hemispinal white matter, contralateral cord, and then the remaining fibers will cross in the ipsilateral side and then send contralateral fibers to reach the motor nuclei of the spinal nerves. We have the extrapyramidal tract, which includes the tectospinal tract, the rubrospinal tract, vestibulospinal tract, and the reticulospinal tract. Here we have the spinal trigeminal tract. As we said, it is this tract that's responsible for the perception of sensation from the face, be it pain sensation or superficial tactile sensations from the face. So we have this spinal trigeminal tract here, the fibers are mainly going through the trigeminal nerve, which is represented by the gaseous ganglion. Here we have the solitary tract. Solitary tract here. It's responsible for some sensations at the level of the tongue and sensory perceptions. So, concerning the associative fibers, they concern mainly the medial longitudinal fasciculus, which is always located in the posterior median portion of the medulla oblongata and located present all throughout the length of the medulla oblongata. Now, the medulla oblongata has relationships, be it with the cisterns of the brainstem, the blood vessels, arterial and venous blood vessels of the brainstem, or the nerves themselves as they originate from the superficial or the surfaces of the medulla oblongata. So talking about the neurovascular relationships, the blood vessels, the cranial nerves, and then the neural parts of the brainstem are intimately linked and in close correlation with some brainstem blood vessels, precisely the anterior inferior cerebellar artery, the superior cerebellar artery, and then posterior inferior cerebellar artery, such that these structures are organized into complexes. The medulla oblongata is mostly related or correlated with the lower complex, which comports posterior inferior cerebellar artery, as we see here, that originates from the vertebral artery, the cerebellomedullary fissure, fissure between the cerebellum and the medulla oblongata. We have the medulla oblongata itself, the inferior cerebellar peduncle, and then the suboccipital surface of the cerebellum. Suboccipital surface of the cerebellum, and the cranial nerves, the glossopharyngeal nerve, the vagus nerve, the accessory nerve as they originate from the retro-olivary sulcus, and then the hypoglossal nerve from the pre-olivary sulcus. So going into detail with the posterior inferior cerebellar artery, because being one of the main branches of the vertebral artery that's responsible for vascularization of the cerebellum, it is one of the structures, the arterial structures that will be encountered during surgical procedures, precisely far lateral procedures that will end up exposing the cerebellomedulla fissure. So the posterior inferior cerebellar artery is considered as that artery that originates most often from the vertebral artery. It has, amongst all of the cerebellar arteries, the most complex and tortuous and variable cause, as well as the most variable area of supply. So with all these, it at the same time means that during surgical procedures, it's difficult to spontaneously identify this posterior inferior cerebellar artery, and it is more prone to injury during surgical procedures. It most often arises from the vertebral artery near the inferior olive, as we can see here. We have the inferior olive, and then we have the vertebral artery. It arises here at the inferior olive and passes around the medulla on both sides. Passes around the medulla, and all through its course, at the level of the anterolateral margin of the medulla, it passes rostral to the rootlets of the hypoglossal nerve at the level of the pre-olivary sulcus. At the level of the posterolateral margin of the medulla, it causes rostral to or between the rootlets of the glossopharyngeal, the vagus, and the accessory nerves before going posteriorly around the cerebellar tonsils and into the cerebellomedullary fissure, just in between here. And as it exits the cerebellomedullary fissure, it gives branches that vascularize the vermis and the suboccipital area of the cerebellar hemisphere. So here we can see, as we said, the origin of the posterior inferior cerebral artery, just close to the olivary, to the olive. On its anterolateral margin, it goes superior, rostral to the hypoglossal rootlets, and then posterolaterally it goes in between. Here in this case, it goes in between the fibers of the accessory nerves. This depicted cause of the posterior inferior cerebellar artery is what is the most frequently identified cause, because as we said, it is one of the arteries that has the most variable root, the most variable cause at the level of the brain stem. So it takes a certain expertise for the neurosurgeon in order to be able to locate and then protect this blood vessel during the surgical procedures. So here again, we have an image that depicts the anterolateral margin, the posterior inferior cerebellar artery. As we said, here we have fibers of the vagus nerve, we have the glossopharyngeal nerve. So we have the retro-olivary sulcus, and as it passes anterolaterally and posterolaterally, it encounters these different rootlets of the various cranial nerves. On the posterolateral margin, we have here again, posterolateral margin, we have the hypoglossal nerve fibers, we have the glossopharyngeal fibers, and then we have the posterior inferior cerebellar artery as it courses and entangles sometime with the rootlets of these cranial nerves. Here we have the posterior view as we said, it goes around the medulla, and posteriorly it goes around the cerebellar tonsils and enters the cerebello-medullary fissure. This fissure between the cerebellum and the medulla oblongata, it enters the fissure, courses in the fissure, and as it exits the fissure, it gives branches for the vermis and the cerebellar hemispheres. So here we can see the cerebellomedulla fissure, which has been exposed with retraction and cut of the cerebellum. And then we have the vein of the cerebellomedullary fissure right here. We have the posterior inferior cerebellar artery as it courses here and gets into cerebellomedullary fissure. So this is relevant because, as we can see, this posterior inferior cerebellar artery is intimately related to the medulla oblongata. So during surgical procedures, particular care has to be taken to separate this posterior inferior cerebellar artery and protect it from injury during the procedures. Here we have a view of the suboccipital surface of the cerebellum. And here we can see laterally we have the spinal cord, we have the vertebral artery as it goes. Here we have an origin of the posterior inferior cerebellar artery, and on both sides we have the fibers of the cranial nerves, which will be better seen with exposure of the cerebellomedullary fissure. Still talking about the posterior inferior cerebellar artery, it is divided into 5 segments. We have the anterior medullary segment, the lateral medullary segment, the tonsillomedullary segment, the telo-velotonsillar segment, and the cortical segment. So each of these segments is depicted here. We have the anterior medullary segment, the lateral medullary segment, tonsillomedullary segment as it goes around the tonsils, telo-velotonsillar segment, and then the cortical segment, which innervates the surface of the suboccipital surface of the cerebellum. Another feature in the neurovascular relationships is the cerebellomedullary fissure. This fissure between the cerebellum and then the medulla oblongata. So in this fissure, we have veins that cause. We have the vein of the cerebellomedullary fissure, one of the main veins, with the vein of the inferior cerebellar peduncle. We have the supratonsillar veins and then the choroidal veins. So here we have an image that depicts cerebellomedullary fissure, cerebellum ahead, and between the medulla ahead and the cerebellum just posteriorly. We have, as other neurovascular structures in relationship with the brain, with the medulla, we have the veins of the brainstem, which are divided into longitudinal vein, which comport the median anterior medullary vein, the lateral anterior medullary vein, and the lateral medullary vein. We have transverse veins, which comport the vein of the pontomedullary sulcus, the transverse medullary veins, and all these veins drain in the petrosal group of the bridging veins in the petrosal sinus. So here we have an image depicting the longitudinal veins. As we said, we have the medial anterior medullary vein in the midline here. We have the transverse veins that cause here we have an image that depicts still the suboccipital surface. Here we can see the vein of the cerebellomedullary fissure, cerebellomedullary fissure that causes in the cerebellomedullary fissure here. We have the posterior inferior cerebellar artery here in its telo-velotonsillar part. And then here we have an image representing the veins in relationship with still with the posterior surface of the medulla oblongata. We have the vein of the cerebellomedullary fissure, amongst which and the medial posterior median vein, which causes here. So talking about each of these veins, we have the median anterior medullary vein, that causes in the main anterior medullary fissure between the two medullary pyramids. So it crosses between the medullary pyramids. It connects superiorly with the median anterior pontomesencephalic vein in the pontomedullary sulcus, and then inferiorly with the anterior spinal vein. The lateral anterior medullary vein, lateral anterior medullary vein, lateral anterior medullary vein, crosses in the anterolateral sulcus here between the pyramids and the olive, and connects superiorly with the vein of the pontomedullary sulcus and inferiorly with the lateral medullary, vein here. Lateral medullary vein, or the retroolivary vein. On the other hand, we have lateral medullary veins that cross between the lateral border of the olive and the foramen of Luschka, at the end of the lateral recess of the fourth ventricle. The retroolivary vein is smaller and crosses along the rostral two-thirds of the retroolivary sulcus, whereas the lateral medullary vein is larger and crosses slightly dorsal to the retroolivary sulcus. So here we can see the lateral medullary vein as it crosses dorsal a little bit to the retroolivary sulcus. And then we have the vein of the pontomedullary sulcus, which crosses in or near the pontomedullary sulcus, that space between the pons and the medulla oblongata below, and connects with the longitudinally oriented veins in the anterior aspect of the pons and the medulla. So part of these longitudinal oriented veins are the median medullary vein here. You have the lateral medullary vein, lateral anterior medullary vein, and this vein connects with those longitudinally oriented medullary veins. We have the transverse medullary veins, which cross anterior and lateral surfaces of the medulla at the level of the medullary pyramid or below. So here, as you can see, we have some of the transverse veins which cross transversely the level of the medulla oblongata. Talking about the cranial nerves, we have, as known, the cranial nerves of the medulla oblongata are the glossopharyngeal nerve, the vagus nerve, the accessory nerve, and the hypoglossal nerve. So the last four pairs of cranial nerves. Talking about the hypoglossal nerve, as we said, it emerges at the level of the pre-olivary sulcus in the form of rootlets, and then the three other nerves emerge at the level of the retroolivary sulcus. As you can see here, we have the retroolivary sulcus. So here we have an image that depicts clearly the hypoglossal nerve originates as rootlets and exits the brain at the level of the anterior margin of the olive. So in the pre-olivary sulcus. So here we are looking at the olive posteriorly. So we have the hypoglossal nerve rootlets that exit the brain anteriorly on the other side there. And most often, the posterior inferior cerebellar artery passes posteriorly around or between these rootlets, as we saw during as we depicted the relationships of the medulla oblongata with the posterior inferior cerebellar artery. Here, concerning the hypoglossal, the glossopharyngeal nerve, the vagus nerve, and the accessory nerve. So they arise as a line of rootlets exiting from the retroolivary sulcus. So precisely concerning the glossopharyngeal nerve, the ninth pair of nerve, it arises most often as one or rarely two rootlets. Most often it is one rootlet compared to the other cranial nerves, which, for example, the accessory nerve, which is many rootlets, the hypoglossal nerve, many rootlets, and the vagus nerve, which is a tight number of rootlets. So the glossopharyngeal nerve arises mostly as one rootlet, posterior to the upper third of the olive, we have the olive, the upper third here, inferior to the pontomedullary sulcus here, and anterior to the foramen of Luschka. It's not well represented here, but as we can see, the choroid plexus that protrudes from the fourth ventricle will just be situated posterior to the roots of this glossopharyngeal nerve here, as well as the vagus nerve. So the foramen of Luschka is just behind the posterior here, and anterior to the foramen of Luschka and the rhomboid lip of the lateral recess of the fourth ventricle. The vagus nerve on the other hand arises as a line of tightly packed rootlets. Not well represented here, but practically it's a line of tightly packed rootlets posterior to the upper third of the olive. So approximately at the same position as the origin of the glossopharyngeal nerve, and they arise at these tightly linked fibers, just inferior to the glossopharyngeal nerve, superior and the superior part of the retroolivary sulcus. The accessory nerve, on the other hand, is an array of widely spread rootlets originating from the medulla and the spinal cord, both of the structures, and originating from below the vagus nerve, just junction between the upper and the middle third of the olive, precisely the retroolivary sulcus. And here we see the posterior inferior cerebellar artery as it interacts with this accessory nerve rootlets. Talking about the cisterna relationships, the cisterns are these dilatations of the subarachnoid space, which contain this cerebrospinal fluid, and then which, on the other hand, contain major vascular structures that surround the brainstem, and not only the brainstem, even at the level of the hemispheres, contain major vascular structures and provide major access during neurosurgical procedures to parts of the brainstem, and in this case to the medulla oblongata. So the medulla oblongata is particularly linked to three cisterns. We have two unpaired cisterns, which are the pre-medullary cistern anteriorly, the cisterna magna posteriorly here, and then paired cisterns on both sides, which are the cerebello-medullary cisterns. Concerning the premedullary cistern, it extends between the anterior part of the medulla and the arachnoid membrane covering the lower part of the clivus, that part just anterior to the medulla oblongata. It has borders superiorly. This is delineated by the junction between the pons and the medulla, where it is separated from the prepontine cistern by the median pontomedullary membrane. See later. We have lateral borders at the dorsal margin of the inferior olive, just in front of the rootlets of the glossopharyngeal, the vagus, and the accessory nerve. We have inferior margins, which are continuous without interruption with the anterior spinal system. So in this cistern, as main nervous structures, we have the glossopharyngeal nerve rootlets that arise into this cistern, as we can see here. As we can see here anteriorly, and we can see here too, as the limit is just in front of the rootlets of the three other medullary cranial nerves. So here we have an image that depicts a bit the medullary system. Here, laterally here we have the cerebello-medullary system, as it is opened here, with the rootlets of the glossopharyngeal, the vagus nerve, and the accessory nerve below. Concerning the cerebello-medullary system, it lies caudal to a junction between the pons above and the medulla, at the level of the pontomedullary sulcus. It is separated by the cerebellopontine cistern, by the lateral pontomedullary membrane, and the premedullary cistern. It is separated by the cerebellopontine system by the lateral pontomedullary membrane, and the premedullary system by the trabeculae just in front of the cranial nerves number 9, 10, and 11. So as we said, the limit for the premedullary system here is laterally just ahead of the rootlet of the glossopharyngeal, the vagus, and the accessory nerves. And the medial limit here is with the trabeculae just in front of the cranial nerves number 9, 10, and 11, as we said. It has inferior borders at the level of the foramen magnum and extends backwards from the dorsal margin on the dorsolateral medulla to the biventral lobe of the cerebellum. It extends backwards, and it communicates with the fourth ventricle's lateral recess through the foramen of Buschka, which we can clearly see when we be looking at the lateral view. Here we have a posterior view of the cerebellomedullary cistern as it is separated from the cerebellopontine cistern by the lateral pontomedullary membrane. And in this cistern, we see the fibers of the vagus nerve, we see the fibers of the accessory nerve, and we see the fibers of the glossopharyngeal nerve. Here again, we have a representation of this cistern from a posterolateral view. We have the choroid plexus, which is just linked to the foramen of Buschka laterally. We have the vestibulocochlear nerve, but mainly we focus on the glossopharyngeal nerve, the vagus nerve, and the accessory nerve fibers. Anteriorly, we have the hypoglossal nerve, and then we have the olive in between with this space above the cerebellomedullary cistern. Talking about the cisterna magna, it lies dorsally to the medulla and the cerebellar vermis. Its posterior wall is formed by the arachnoid membrane that forms the inner surface of the occipital bone just above the foramen magnum. Characteristically, in this cistern, we have a trabeculae, mesh-like trabeculae originating from the arachnoid matter that extend to the cerebellar tonsils and to the medulla and the margin of the foramen of Magendie, the medial foramen of the fourth ventricle. It projects superiorly into and posterior to the cerebellar veins, anterior to the cerebellomedullary cistern, and inferiorly communicates with the posterior cistern as it is crossed by the posterior inferior cerebellar artery. So here we have an image that depicts a little bit most or all of these cisterns. We have here posteriorly the cisterna magna with the dense fiber, the dense mesh-like networks of trabeculae that may sometimes pose certain number of problems during surgical procedures through the cisterna magna. You have the premedullary cistern right here, cisterna magna premedullary cistern. We have the interpeduncular cistern here, and the membrane separating the lateral pontomesencephalic membrane separating the mesencephalic cisterns from the pontine cisterns. The vascularization of the medulla oblongata is assured mainly by branches of the vertebral artery too. So we have the paramedian branches and the anterior spinal artery. We have posteriorly the vertebral artery and the posterior inferior cerebellar artery, knowing that infarction or occlusion of this posterior inferior cerebellar artery will be responsible for what is clinically known as the lateral medullary syndrome. And here we have some functions of the medulla oblongata, because as we know, this medulla oblongata being part of the brainstem has particular functions that render it a delicate structure or organ during neurosurgical procedures. So part of these functions are linked to the tracts in the white matter. It has sensory functions as it linked to the spinal thalamic tract, the spinal medullothalamic tract for pain sensation, temperature sensation, vibratory. We have the motor functions, as these medulla oblongata serves as a relay to the fibers for the corticospinal tract as they deposit in the form of at the level of the inferior portion of the medulla oblongata and go anteriorly as pyramids. And the medulla oblongata has vegetative functions because through this gray matter present in the medulla oblongata, it controls some basic functions of the organism linked, for example, to the cardiovascular system functioning, linked to the respiratory system, the centers for respiration, the cardiovascular centers, vasomotor centers. Clinically, in cases of medulla oblongata tumors, we have clinical signs which vary according to the type of tumor of the medulla oblongata. So we can have posterior fossa symptoms like vomiting, headache, ataxia, which can be linked to compression of either a spinal cerebellar tract or the cerebellum itself. We have signs of ventricular system obstruction in case of compression, for example, at the level of the posterior wall of the medulla oblongata with compression of the fourth ventricle. And we can have medullary symptoms, like symptoms linked to compression of white matter fibers, be it motor symptoms, sensory symptoms, and also signs of cranial nerve compression. But most often, these white matter fibers, these symptoms linked to white matter fiber compression are late signs of the medullary tumors. So talking about some surgical approaches, there are three main steps during surgical approaches, three main questions. Question is, which surgical approach to take? Which are the safe points of entry? And how do we proceed to remove the lesion? Because the medulla oblongata, as we said, as part of the brainstem, has these vital functions, these functions linked to the autonomous nervous system, be it the vasomotor functions, respiratory functions. So access to this neurological structure is always very delicate, as it sometimes entails separation of some crucial white matter fibers present in the medulla oblongata. So most often the surgical approaches vary depending on the surface considered. So during surgical approaches to the anterolateral surface of the medulla oblongata, the surgical procedure most used is the far lateral approach associated with occipital cranectomy with resection of the posterior arc of the atlas, the C1 vertebra. Apart from that, we can have the retrosigmoid approach. And then during approaches to the posterior surface, it's either an intraventricular approach, in which case it is mostly associated with a lot of neurological deficits, or an inferior approach precisely through the median suboccipital craniectomy. So here we have an image that depicts a little bit the far lateral approach. to the medulla oblongata, the far lateral approach. You have the median suboccipital approach for the posterior surfaces, far lateral approach that through the cerebellomedullary system give access to parts of the anterolateral medulla oblongata. And here we have an image that depicts a little bit the locations, the orientation of the far lateral approach. As we said, we have a resection of part of a suboccipital resection and a resection of the posterior arc of the C1 vertebra. So in this far lateral approach, it is most preconized for anterior and anterolateral brainstem lesions, but mainly when it concerns the medulla oblongata, it's mostly used for anterolateral medulla oblongata lesions because it provides better exposure, and compared to the retrosigmoid approach, it provides better inferior and superior view and access to the anterior brainstem. So it is mostly recognized, especially with the anterolateral medullary lesions. It permits adequate access to the vertebral artery, the posterior inferior cerebellar artery, the upper cervical cord, and the medulla, mostly anterolaterally, the foramen magnum, the caudal segment of the clavus, and the jugular foramen. So here we can see the safe entry zones. Most often for the far lateral approach, the safe entry zone is the retro-olivary sulcus right here. The most used safe entry zone is retro-olivary sulcus as it provides a surgical space of 13.5 milliliters craniocaudally, 7 millimeters transversely, and 3.5 millimeters anterior-posteriorly. So for the far lateral approach, one of the used safe entry zones is the retro-olivary sulcus. And then for the posterior approaches, some safe entry zones are the posterior median fissure, the posterior intermediate sulcus, the posterolateral sulcus, which are used to access this internal part of the medulla oblongata. So depicting a little bit the far lateral approach. In this approach, we have most often it is the park bench position that's used to perform the approach. During the approach, it is an incision that's performed beginning at the level of the external auditory meatus and ending at the level of the C2 vertebra, making sure to be posterior to the dorsal margin of the sternocleidomastoid muscle here. So with this incision, we have a certain view of the posterolateral part of the occipital bone, but dissection of the muscle tissue is sometimes a little bit difficult. And knowing that we have the vertebral artery just below and the other vital structures, it sometimes gets, sometimes the surgeon will prefer performing a hockey stick incision because it permits more exposure, it permits anatomical repair, anatomical dissection, and better exposure than sometimes this incision at the level of the lateral suboccipital surface. So after the incision, we have the exposure of the important structures, the vertebral artery, which has to be exposed and protected, the posterior arc of the atlas, the C1 vertebra, which too has to be exposed and protected. And it is most often advised that since just below this muscle tissues as it is dissected during the incision, taking for example hockey stick incision, after the dissection of this subcutaneous tissue and the muscle tissue, the vertebral artery being not really that far, it is mostly advised to locate it and After locating it, separate it from the overlying tissue before progression, because we know the posterior inferior cerebellar artery, which vascularizes the lateral part of the medulla oblongata, originates from this artery, and damage to this artery will not only cause the medullary infarction manifested in the form of a lateral medullary syndrome, but more so that it can cause damage to the other brain structures, as this artery contributes to the vascularization of the cerebral hemispheres as a whole. Further, after this location and protection of the main structures, we have the craniotomy that is performed infralaterally, taking care to protect the vertebral artery. And besides, we have resection of the posterior arc of C2. This resection permits better exposure of this posterolateral region and provides easier access to this region. Thereafter the craniotomy, we have the dural opening, taking care still of the vertebral artery, because sometimes the vertebral artery, the posterior inferior cerebellar artery, can originate just below the part of the vertebral artery that crosses the dura mater. After the dural incision, we have the intradural dissection with the adequate exposure of the different structures and the location of the landmarks being the medullary olive, landmarks being the C1 rootlets here. And with further exposure, we can visualize the cerebellomedullary fissure laterally, and the organs of these structures of the cerebellomedullary fissure, or extend more depending on the location of the tumor. So in conclusion, the medulla oblongata is this neural structure that originates from the brain vesicles, precisely the myelencephalon, limited above by the pons and inferiorly by that horizontal line that follows the C1 spinal nerve roots. It is an important structure because not only internally does it have white matter fibers that are linked to precious functions of the nervous system, precisely motor and sensory functions, but more to that, it has nuclei that are responsible for the main activities of the cranial nerves in part, and then some properties of the autonomous nervous system, be it the cardiovascular functioning, the respiratory system. And surgical approaches to this organ have to take into consideration the safe entry zones, take into consideration the superficial structures that has to be crossed from the skin inwards, and then care has to be taken mostly when one of the most used surgical procedures, which is the far lateral approach. Care has to be taken not to injure the main arterial vessels such as the vertebral artery during the procedure, and identify and protect the posterior inferior cerebellar artery. Thank you for your kind attention.
Dr. Bennett, we can't get you. Your microphone is off.
John?
Your mic is,
John,
your mic is
your microphone is muted.
Dr. John, it's not getting. Dr. John, your microphone is mute.
I'm sorry, I'm supposed to know what I'm doing.
Okay.
Okay.
Well, could you please introduce yourself again, Zolo? I'm sorry.
Okay, I am Zulu. I'm a fifth year medical student from the University of Buea, Faculty of Health Sciences in Cameroon.
You're welcome. Okay, let's introduce Steve. Hello, Steve, a new arrival. Hi, Steve. Could you please introduce yourself? Can you hear me okay, Steve?
Yes, I can hear you.
Oh, good.
I'm Steve. I'm a fifth-year medical student from FHS Cameroon.
Oh, excellent. Welcome. Welcome. No, the value of this, Dylan, is to watch, because repetition helps a lot with anatomy, going over and over and over it until you know it by heart.
Exactly.
It's part of your brain. You know, for you guys, neuroanatomy has to be part of your brain. It's going to be in there. And you can watch lectures like this and add some stuff and strengthen some other stuff. But it's repetition, 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 which is, this would be an excellent video just to go over if you were, a neurosurgeon or somebody operating in that area or studying for exam, just go over and over and over so that it's part of your mind.
These are great video summaries of the different chapters. Yeah,
no, that's the way, that's a great way that that Ulrich organized it, a series. I mean, that's what Samer Hose from Iraq is doing, a series of neurosurgical lectures so that you guys can watch the series and get, kind of an organized approach to education and neuroanatomy. So yeah, you've given a couple of great ones, and just as good as anywhere in the world. Those lectures are just like, you could do that in the grand rounds anywhere, because that's the basic language of a neurosurgeon. Is basic. It's the language. It's like trying to communicate. If you don't know the language, you can't communicate. You move your hands a lot and make gestures, but neurosurgery anatomy is the language that you gotta know cold.
Basic language, especially for aspiring neurosurgeons like us, because we really need to master those basics.
Yes, that's the first step in being a great neurosurgeon, is mastering neurosurgery.
I saw Dr. Cabulo.
Oh, is Dr. Cabulo here? He was here for a bit. I'm sorry, I didn't scare him off, but he believes in this type of education, and he participates a lot. And even neurosurgeons, they brush up before they do a certain procedure. They brush up on the neuroanatomy. But they're not seeing it for the first time. They're seeing it probably for the 50th time, but they need to refresh it more. And maybe the possible anomalies, because as you guys will learn, if you haven't learned already, there's lots of anomalies. When you get in there, sometimes the artery won't be in the place you think it is, or the vein won't be that, or a certain structure won't be where you expect it. And you're able to recognize that. You're able to say, whoa, that's not normal. That's an anomaly in this patient, which I'm sure you'll see lots of that. So,
but that's at such a moment, it becomes a matter of experience by the neurosurgeon, because with the neurosurgeon's experience, there are certain things that he can see that even if we read, no matter how long, we cannot see.
Well, we're trying to, in Kenya, we're trying to set up a cadaver lab where we broadcast so that you guys can see it. And basically, of course, it's best to be there in Kenya, in Nairobi, but sometimes you can't go. So we're trying to set it up so that the dissector has headphones, like, I don't see if I have them here somewhere. Oh, there I go. These are excellent headphones. And I don't think they're wireless headphones. And I'll send a set to you guys. But basically, the dissector can just wear these headphones and dissect and interact with you guys on the panel. And we're going to get a smartphone. Where's my smartphone here? I don't have it here. We'll have a smartphone. It's around here somewhere. We'll have a smartphone above the cadaver. Now, smartphones are excellent cameras, excellent. And so that smartphone would be a panelist in the discussion, like it would be Zolo's camera looking down at the field. And it's easy to set up. The person would have to enter the webcast on Zoom in the smartphone, then put it in the stand so that it's a camera, overhead camera with good resolution. Just like the resolution is good on my screen right now, it's good resolution. So.
How did you improve the resolution, John?
I'm sorry?
How did you improve the resolution?
Well, it helps to have good bandwidth. I mean, bandwidth is the thing that really, I mean, it's tough now. Like, for example, your resolution is not too good. It's sufficient, and it's excellent for today's presentation. And we're more interested in seeing the PowerPoint slides, which were excellent resolution. Like, look at Zolo's screen. You see how clear it is? I think he's probably got a little stronger internet connection, and Steve has a pretty good internet connection. Some days you have it, and some days you don't. You know, like I have a broadband, so it's different. I mean, it's powerful, and but look at Zolo. He's got an excellent resolution. Look how good his screen looks. Do you know what I mean?
Yeah, I understand. It happens, especially here. They are really.
And that's a smartphone. That's a smartphone. I think. Do you have your smartphone with you, Dylan?
Yeah, I have my smartphone.
Yeah, go get into the Hangout with a smartphone. Get into this webcast with a smartphone. You're going to see the difference in the picture.
Yeah, I also think the resolution is a function of the bandwidth you have, and also the quality of the camera. The camera you're using also, even smartphones have better cameras than laptops and others.
Okay, so you actually can test the bandwidth. You go to, well, let me show you, and this will be part of the education of you guys. Wherever you're at, you can always test the power of your. I'm going to screen share here. You can always test on the power of your connection. It's speedtest.net. Okay, it's speedtest.net. Where if you ever need to test your connection, like I'm going to test mine now, it's high because it's wired. It's wired, and you're going to see how fast it is. It's important for me as a host to have a powerful connection. And I know you guys are going to get jealous. I know that. But I'm in an ideal situation. I'm in the city. I'm very close to great internet. And some days you guys will have this. Very shortly, you'll have it. We never had this a few years ago. A few years ago, we never had this. Time is going to make every bandwidth better and better. And once wireless, I mean, those are good numbers. But I'm sure you guys, like Zolo, do that test on yours. I bet you got decent numbers. Test.net. And if you can do it too, Dylan, it'll probably take a while, Dylan, for yours to download. But yeah, don't be ashamed. I mean, you had a good connection. It was sufficient for your presentation.
You said that it's VTest.
Speedtest.net.
Okay. It may take a few minutes. Well, why don't we all end this broadcast? We can toy around. So thank you very much, everyone. I'm going to go off the air officially, and we'll see you next Friday.
Okay, thanks everyone.